Right, so looking at the reality of conducting visits to either a detainee, the prisoner, or the patient. The issue around visits is there's got to be a purpose to doing it, not just a tick box exercise. It's all about safety of the person themselves, but also safety of staff. There's a purpose to it. As far as possible, we want continuity of the same staff member doing the checks, so that that person then is in a better position to work out, is there anything changing either positively or negatively? Whereas if it's different people all the time, there's no comparable for people, so they can't compare it. So continuity of the same person is a really good idea. Next thing, ensuring that when the person actually goes, they've been briefed. They need to know what are the concerns, what are the health issues with the person, is there any previous in relation to self-harm, suicide attempts, injuries to staff, have they got any previous in relation to faking it, etc., etc., any medical needs? Because, for example, just think about if somebody was diabetic and they're going downhill because they've not been eating, they're stressed, or the custody staff haven't been offering them food, their condition is deteriorating. We've got potentially a medical emergency on our hands, but the person doing the visits, because they don't understand that they've got an issue with diabetes, they just think that they're just being calm, quiet, a bit drowsy. Other things there, that any member of staff going down and on the roll of visits should always be in possession of the key to get in case of an emergency, should know exactly where the emergency buttons are to call for help, and be in possession of a ligature cutter. Because again, if you can get into the room, if somebody is ligatured, but then you've got nothing with you to cut them down, so as part of your emergency preparedness, then decisions need to be made about ideally individual carrying, or whoever's on the roll of doing the checks takes the key with ligature cutters attached to that then, so they're always in possession of them. It's also important that you can actually see the person. So if the person's laying there and they've covered the head over, you know, how can you establish that that person is actually okay? So as far as possible, you want to make sure you can see them. Now, there might be some issues, say, for example, through the night, when then you've got to rely a lot more on hearing. Are they breathing right? Does it sound right? Is the movement? All the time, we've got to be thinking of, how can I satisfy myself that this person is actually alive, and not just alive, but safe and well? They're not deteriorating and going into a coma. Talk to them. You know, it's essential that you positively engage with the person all the time. It's no good just looking at them and then scurrying off, because by engaging the person in conversation, it's a massive indicator in relation to the person's tone, mood. Are they actually increasing or decreasing in relation to things? And especially if someone's mental health is rapidly declining, we need to be able to take this into consideration. How are they conversing now? Are they more talkative than a few hours ago, less talkative? What kind of terminology are they using? Are they using self-loathing terminology now? Are they asking for food? Were they asking for food? So it's essential that we converse with them and that we have a conversation with them. So when we're doing the checks, we can be satisfied that there's no indicators of risk in this conversation, or if there is an indicator of risk, that we've acknowledged it, we understand it, and what we're trying to do is keep the person going up, not going down. And then ensuring that we record it, and we record it in detail, not just a visit correct or visit all in order. It needs to have some detail to it, so that at a later date, when either colleagues are taking over the visits, or there's any inquiry in relation to, well, what actually happened, we can then put on there that we had the conversation, we asked them this, they said that, we offered them a drink of water, they declined. So then we can keep a track of thinking, that person now hasn't drunk for 6 hours, or they've not eaten for 8 hours. It's essential from the welfare point of view that we can keep track of the person in a holistic care purpose. So that's just a very rapid cover in relation to the purpose of the visits and how to actually conduct them. But if there's any doubts about the medical condition, then if you're not currently a healthcare professional, then there's no harm in getting the healthcare professional involved with you and the custody staff, so that you go down there in pairs. And again, having that conversation and deciding all the time that what is the purpose of doing this. It's pointless just going to visit just for a tick in the box exercise. There's got to be a purpose to everything that you're doing for that person, and ultimately it's all about ensuring safety in the custody areas. So whether that custody be police, prison, mental health, child secure sector, but it's about safety for everybody, and picking up quite quickly when anything's going wrong on those subtle alterations in relation to the person's conversation, behaviour, attitude. Any questions? Give us an email. Thank you.